All right, hello and welcome. We are going to talk about management of clients with cerebral vascular disorders. This is, again, we have kind of switched gears. We're using the Bruin Sutter's medical surgical nursing textbook. 15th edition is more likely what you have access to online at CoursePoint, but follow along here and I will give you most of what you need, but please know that that chapter is up for reference and we will do some things in class to kind of tie in this learning. Okay, cerebrovascular disorders, again, functional abnormality of the CNS that occurs when the blood supply to the brain is disrupted. So just like you can have a heart attack due to like a clot or ischemia in the heart, a stroke is that ischemia in the brain. So it can be disrupted based on ischemia. It can be disrupted based on a bleed, and we'll talk about that in a little bit. But the stroke is the primary cerebrovascular disorder. It's the 5th leading cause of death in the United States. It's like the leading cause of long-term disability in the United States, and the financial implications of someone having a stroke or CVA is profound, especially if there are major deficits. Risk factors, I love a good risk factor chart. So, but thinking about modifiable versus non-modifiable, age, gender, ethnicity. But again, there's a good chart in your book about it. But modifiable versus non-modifiable. But thinking about modifiable risk factors for stroke, carotid stenosis, do they have AFib? Are this patient diabetic? Do they have high cholesterol? Excessive alcohol consumption, and that's considered more than 2 drinks in a day. Hypercoagulable state, so maybe they have a clotting disorder that's making them prone for blood clots. Hypertension, controlling hypertension is a major risk factor for preventing stroke. So those patients that you have that we learned about last course about, controlled or versus uncontrolled hypertension, that leads right into risk for stroke. Migraine, obesity, sedentary lifestyle, sleep apnea, and smoking. Of course, African Americans are at high risk, but modifiable risk factors for ischemic stroke. It seems interesting that you could think that, carotid stenosis and other things are modifiable, or AFib, but again, thinking that these are things that can be treated or modified in some way. Women who are taking oral contraceptives are at higher risk. Of course, smoking, drug abuse, and so there's risk factors listed here, but definitely also thinking about heart issues, AFib, anything that's putting them at more risk for, even poor perfusion or poor contractility of the heart, where the blood's just sitting in the heart in some way, puts people at risk for stroke. Also called a brain attack, sudden loss of function resulting from the disruption again of that blood flow. It can be ischemic or hemorrhagic. We'll talk about the differences here in a minute. Ischemic stroke is the disruption of blood flow caused by an obstruction. Usually it's a thrombus. Those blood clots take flight basically and go where they want to from the heart. Especially with AFib, it's a direct route to the brain. So they can cause infarction. You can have fat embolism, other things too, but ischemic stroke means that there's some sort of ischemia or loss of blood flow based on an obstruction. You could have a large artery thrombosis, small artery, you can have all kinds, and we won't get into the weeds of the types of ischemic stroke. But basically, the large artery ones are typically caused by plaques, and then small penetrating they can affect more than one area. So cardiogenic is specifically related to AFib, and like any of those valve problems that we were talking about, where blood's maybe just sitting in the heart and clotting and then finally getting squeezed and circulated out and then causing a stroke. There also can be cryptogenic, where we just don't know why. Cocaine, blood and clotting disorders, again, migraines, vasospasms, all those can cause ischemic strokes. Pathophysiology of the ischemic stroke, we're not going to get into the weeds of that, but there you have it. Manifestations of ischemic stroke, it's going to depend on the location. Your brain's cool, but based on where the problem is and what that part of your brain controls is how you're going to see the manifestations or the symptoms. But often you will see numbness or weakness of the face, arm, leg, especially like one side. Confusion or change in mental status, trouble understanding their speech, difficulty walking, dizziness, loss of balance or coordination, sudden severe headache, or perceptual or visual disturbances. Symptoms, again, depend on the location, the lesion, the size, the area, how inadequate the perfusion is, and if there's any like collateral blood flow to that area. But we'll talk about that in class a little bit more. But those signs of stroke, we want to recognize those, because just like time is muscle in the heart, it's also brain matter, and the quicker we act, the more interventions hopefully we can put in place. Key terms, and we will get into these, we'll do some activities in class, but hemiplegia, paralysis on one side of the body or part of it, hemiplegia. So thinking about being paraplegic or having paralysis, that's where that word comes from. So paralysis on one side of the body, hemi meaning one side. Hemiparesis is just weakness. So whereas plegia is paralysis, paresis is weakness. And you are going to see that on one side of the body. Dysphagia, you'll see here. I don't know if it's listed in here, but dysphagia, think the way it's spelled, dysphagia, dysphagia, inability to swallow safely. So I use that GI and pull that out for dysphagia. As aphasia, I think about aphasia with an S. It's my inability to express myself. There's an issue with my speech. And it can be an inability to express it, an ability to understand it. Dysarthria is a difficulty in speaking, like truly like dysarthria, like I'm unable to articulate. I cannot speak the words. I have dysphagia, impaired speech. So basically caused by paralysis of the muscles responsible for producing speech. So whereas aphasia is like, hey, I can have expressive aphasia, like I know what I want to say and I'm trying to say fork, but I say cat. So I say the completely wrong word. I'm having issues with expressive or receptive aphasia. That's the understanding the language, versus the dysarthria or dysphagia with an S, not GI, but S. Dysphagia is my inability to speak, and we'll get into that in the class and try to make a little bit more sense of those. Apraxia is the ability to perform a previously learned action. So maybe I used to be able to tie my shoes and now I cannot. And then a patient could also make substitutions for desired words and syllables there. So aposia, think about OP, it's like optical. So that's basically an issue with blindness or impaired visual field. And then agnosia is the loss of the ability to recognize objects through sensory. So it's basically a sensory loss. And it can be just a particular sensory system. So whether it's by touch, by sight, by sound, but that's what agnosia is. We may not get, when we think about, another word I think about that's similar is agnostic, but like that, like, I don't know, like, I don't understand, I don't believe. But again, like that's like, so I just somehow can't recognize this anymore. Okay. Again, we'll get into those in class, but here they are. We will get into like understanding what the different deficits are, and you may see those on test questions. So, transient ischemic attack is basically as it sounds. So just like you can have an ischemic stroke, a TIA means the keyword there is the T, the transient. So it doesn't stay. It's temporary, usually resolves within 24 hours. It's kind of a warning sign that, this client is at risk for stroke. And it's still the same, sudden loss of motor, sensory, visual function. Honestly, my sister had one not long ago and she's very young, but her issue is as a result of very poor cardiac perfusion and congestive heart failure after having a couple of babies. But as a result, her function is like 30%. She has very low squeeze to her heart, so blood kind of sits in pools. She's at risk for clots, is now on Eliquis as a result of having a TIA, but she kind of described it as the most terrifying thing in the world because she basically lost her balance, was able to get herself onto the ground, but couldn't talk, could kind of motion, but was not able to speak. And long story short, after CT scan, and which is how they diagnose a TIA versus an ischemic stroke or hemorrhagic stroke, is that based on CT scan or imaging, it's typically resolving, or it's not even there anymore. You have the symptoms, but it's, again, that warning. So that you have a workup, it's required to treat and prevent irreversible deficits. But a transient is, as it sounds, usually resolves in 24 hours, but definitely a warning sign that your client is at risk for stroke. Preventative treatment. We aren't going to get into the weeds of this, but a carotid endarterectomy is like if there's plaques and there's an issue or a stenosis to the carotid artery, specifically for carotid artery stenosis, they will actually go in and open that up. Anticoagulation therapy for patients with AFib or clotting disorders, antiplatelet therapy. So that would be like your aspirins and such. Statins, if the patient has high cholesterol, we're treating that. And then, of course, antihypertensive medications. So thinking about those same risk factors, these are some of the things that we're doing to combat them for treatment and prevention of TIA and stroke. Here's a picture of carotid endarterectomy. If you want to know what that looks like, there you have it. We're not going to get into the weeds of it, but that's what they're doing. Open that on up. Medical management of the acute phase of stroke, it is like prompt diagnosis. We need to know when this person's last normal was. There's some NIHSS standards for assessment for stroke. There's scoring. We're not going to get into the weeds of that. But they can be given for an ischemic stroke. Again, due to occlusion, clots, plaques, blood clot, etc., due to a blood clot in the brain. They can be given TPA, which is basically all of those medications, and there's some newer ones too, not just TPA, but they're like they say TPACE on the end, like PASE, Altapace. There's some PACEs, PASE medications that are designed to break up blood clots. If you've ever worked with like central lines, like especially PICC lines, sometimes you actually can let a TPA dwell in a PICC line to bust up the clot and clear those out. But it's the same concept. It is there to designed to break up, bust up, kind of like a rotor-rooter, bust up that blood clot. It's IV dosage, weight-based, strict monitoring. This is going to be an ICU patient, so we're not going to get into like a bunch of the weeds of that, but elevated head of bed, maintain airway ventilation, hemodynamic monitoring, and neurological assessment. Because obviously the risk is going to be bleeding, and there's going to be criteria that will rule people out, even though we knew when they were last normal and they have an ischemic stroke. There are other things that can make them not eligible for TPA, but specifically based around that risk for bleeding. There is a little chart in your book. Just know TPA, altapaces, they are what we're going to use for an ischemic stroke. Ischemic, as a result of a blood clot and the occlusion. Ischemic stroke, we can use a clot buster upper to combat that, again, based on certain criteria, but just know, tie this thrombolytic therapy to an ischemic stroke, not a hemorrhagic one. All right, here we are with hemorrhagic stroke. Just know that's defined not the same as a brain bleed like from trauma, but a hemorrhagic stroke, meaning that it is a primary intracerebral hemorrhage. I am bleeding from in the brain, spontaneous ruptures of small blood vessels, typically caused by uncontrolled hypertension. Might see it with cerebral atherosclerosis, deeper in the brain structures. Basically could be like a ruptured aneurysm, but it's spontaneous bleeding of the brain, not related to trauma, often related to uncontrolled type hypertension, etc. Manifestations similar to ischemic stroke, other than they're probably going to have the worst headache they've ever had in their whole entire life, and it's going to be sudden onset and it's going to be excruciating. They can have early and sudden changes in LOC, because if you think about kind of what's happening there, they can have pretty quick changes with pressure. They can have that vomiting, bleeding, again, because that change in ICP, you're going to see that manifest maybe in projectile vomiting again. So bad news. The symptoms from, those particular symptoms differ. Prognosis depends on the neurological condition of the patient, any comorbidities, where is it located, and can we get it stopped, or is it too severe? So this is kind of a watch and pray. I have to say, I have a friend who's currently going through this with a loved one. And it really is just, it's taking time, because if it's not in an area that they can get into it, they have to hopefully let it resolve on its own, have the bleeding stop on its own, etc. Manifestations from hemorrhagic stroke, unfortunately, this can be a watch and pray scenario. Or positive vibes. Medical management, CT scan, lumbar puncture, again, confirming, what's going on with the ICP, cares, again, primarily supportive of those, thoughts and prayers, or however, we really are just supporting them based on what they have going on. Oxygen, trying to treat any kind of vasospasms, treat any issues with increased ICP, obviously trying to keep their blood pressure in a happy state where it's not hypertensive, but at the same time we want perfusion to the brain. Looking for, potential for seizures and prevention of further bleeding. So we're going to do a CT MRI for diagnosis, and then we're going to treat any cerebral hypoxia and support that with some oxygen. Vasospasm, again, that's that narrow as it sounds like. We have bladder spasms, where we think about that, spastic movement. So the lumen can be kind of having some spasticity there. Serious complications of a subarachnoid hemorrhage, and we don't really know why it happens. Again, ICP, and then treatment for hypertension is super critical. Nursing management, again, monitoring ongoing symptoms, vital signs, neuroassessments, LOC, speech, people changes, INO, kind of everything we talked about in our lecture about, the patient with a neurological issue or deficit. We're going to continue to support them with the addition of oxygenation, and then hopefully trying to mitigate any further risk for bleeding. After the acute phase, it's just going to be mental status. Where did they kind of land after this deficit and this, infarct to the brain, basically. Do they have sensory perception issues? So all the support's going to be monitoring around what are the manifestations or symptoms from this stroke. Are they having swallowing difficulty? Do they need nutritional support? Again, skin integrity management, activity tolerance, bowel and bladder function. Collaborative problems decrease cerebral blood flow. So if they've got an issue with bleeding, and we're trying to, there is a dance and a balance for trying to maintain them not being hypertensive, but at the same time making sure they have adequate cerebral blood flow, and especially if they have a hemorrhagic stroke, that could be a problem. Inadequate oxygen delivery to the brain. Again, we're supporting that with O2, and then, risk for pneumonia, and basically protecting that airway. Nursing interventions for the patient recovering from an ischemic stroke. We're just trying to improve their mobility and prevent any joint deformities or contractures, prevent shoulder adduction, and then abduction, so taking, that shoulder away from the body, but we're trying to prevent some of that. There seems to be this, hallmark with shoulder pain too with a stroke patient, so trying to manage that. Changing positions, again, every 2 hours, establishing an exercise program, passive or active range of motion at least twice a day, but really more like 4 or 5 times a day. Prepare for ambulation, get them out of bed as soon as possible, and again, preventing that shoulder pain that seems to be indicative and goes along with that ischemic stroke. Continued interventions, self-care, helping them do as much as they can themselves, modifying clothing if we need to, things that are easy to get off and on, especially if they have that one-sided deficit. And when we think about that hemiparesis, so if my brain, the ischemic stroke was on the right side of my brain, I'm going to see left-sided hemiparesis. I'm going to have left-sided effects, and vice versa. So it's opposite of whatever side of the brain was affected. If I've got left-sided weakness, it was the right side of my brain that was affected by the stroke, and vice versa. So hopefully that makes sense. Please let me know if you have any questions about that, or just kind of marinate on that a little bit. But that's how we see those manifestations and how we describe it. We describe it on the side of the deficit, not on the side of the stroke. So if we say it was a right-sided stroke and they have left-sided hemiparesis, we're describing the deficit on the side that is affected. Speech therapy, having the patient sit upright, chin tuck, just making sure, thinking back to essentials, safe eating, thickened liquids if we need to, pureed diet if we need to, for patients that have dysphagia, GIA, as a result of their stroke. Continued interventions, bowel and bladder control. Again, we don't want them to be constipated, but we're also going to manage for any incontinence and manage, prevent injury to the skin. Family coping, especially if there's any kind of, sexual dysfunction, partner relationship, expectations, the grief that's surrounding that, and then monitoring and managing any potential complications. Hemorrhagic stroke, again, we're going to do that neurological assessment and just kind of monitor what's going on. We're looking for, do they have that nuchal rigidity? Do they have any other neurodeficits? Any deficits based on cranial nerves that are affected? Motor and sensory dysfunction, sluggish pupillary reaction. We're really just doing a lot of neuro assessment and monitoring this patient and supporting them. Collaborative problems, again, those vasospasms, seizures, hydrocephalus, hydrocephalus, however you want to pronounce it, but basically an increase of CFS and fluid in the brain as a result of this perfusion issue. So they may start to have more increasing pressure there. And then rebleeding issues, and then of course hyponatremia. So we're going to just kind of keep an eye on it. Hypertension is the most serious and modifiable risk for rebleeding. Hydrocephalus, we're usually fixing that with a shunt, whether that's external initially or an internal long-term. Hyponatremia, because of a subarachnoid hemorrhage, can also cause some of the vasospasm. So we're just going to keep an eye, monitor on their labs and electrolytes. Planning goals for a patient with a hemorrhagic stroke, improve perfusion, hopefully relief of anxiety, and then absence of complications. Again, that's supportive care. Optimizing cerebral tissue perfusion, implementing aneurysm precautions. So head a bit up 30 degrees, non-stimulating environment, preventing further bleeding, any kind of activity that would increase ICP we talked about. So again, that any having to bear down. So we're going to keep their bowels moving easily and not having them have to bear down or be constipated. Any acute flexion or rotation of the neck and head. So we're going to be really careful about how we position this patient and not doing anything sudden where they're going to move their head and neck out of line with the rest of their body. Again, stool softeners, non-stimulating stressful environment, dim lighting, maybe no TV, no radio, and then visitors may be restricted for this client. So we kind of talked about that in that other lecture, but this would be a hemorrhagic stroke and a type of patient where those would be put into place. Again, relieving anxiety, continuing to help with reorienting patients. These are precautions, and then promoting self-care as possible. Aneurysm precautions for patients, basically, again, that non-stimulating environment to prevent that increased ICP is what that means by that. They may be on bed rest in a quiet, non-stressful environment. Looking at pain and anxiety, head of bed 30 to 45 degrees to promote that venous drainage. And then again, avoiding any movements or activity or strain that will cause a quick ICP change. SCDs, Lovenox for risks of DVT, but at the same, you're going to have to use that as a balance. So it's definitely going to be SCDs. May or may not use like Lovenox or something like that. Again, the risk for bleeding, we're going to try to figure out what's best. Home care education for the client. So they may be, have all kinds of referrals to all kinds of therapies. So thinking about that too, we've learned about all kinds of, speech, occupational, physical. They may be going to extended care facility for rehab. But home care education, we're going to try to prevent subsequent strokes. Definitely health promotion, follow-up care. Again, look at those modifiable risk factors. Is there anything that we can change? Medication education as appropriate. Again, safety, looking at, do they have grab bars in their home for the shower? Do they have, rugs that they're now, are a tripping hazard? Is there lighting? So those ADLs and adaptive strategies, again, is there any changes to their diet, nutrition, swallowing? So again, we're going to pull in that speech therapy, and they may need tube feeds if they're not safe to swallow, if that's, the choice that they've made that they want to, and they've had some of those interventions for unsafe swallow. Elimination, we're going to look at bowel and bladder programs, catheter uses appropriate, exercise and activities for recreation and diversion. And then, of course, socialization, because there can be some isolation. So those are community resources for the patient and for their families.